Imagine this. You walk into a hospital with chest pain. The doctor does tests. Tomorrow, you have your results and they tell you you need a surgery. You ask, what if we don't want? They say, let me show you. And they pull up your perfect virtual copy of your heart, not a generic heart, your heart. Then they run a simulation. They perform the surgery in the digital version first. They show you exactly what's going to happen. They show you the risks, recovery time, what your life looks like in next 6 months if you do the surgery, and what it looks like if you do not. This isn't a science fiction. Hospitals are already doing this now, and this is called as digital twin. But here is the real question. If healthcare can create a digital version of your heart, your brain, your disease, how much should we trust it? Because if digital twin is right, it can save time, reduce risk, and personalize the care. But if it's wrong, incomplete, or poorly governed, it creates a new kind of healthcare risk. So in this video, we will understand where digital twins came from. We will deep dive into 3 clinical use cases where digital twins are no longer just an idea. They are already proving their values in the real world and the future of digital twins. Let's get started. Most people think that digital twins are new in healthcare. A 2020s invention, something born after AI, cloud, Gen AI. But that's not true. To understand digital twins, we have to go back to April 1970. Apollo 13. 3 astronauts are almost 200,000 miles away from Earth. Suddenly, an oxygen tank explodes. The spacecraft is damaged. Oxygen is leaking, power is dropping, and the astronauts may have only hours to survive. NASA engineers cannot go to space and fix the spacecraft. They cannot afford to guess. They cannot say, let's try this and see what happens. So what do? They recreate the problem on Earth using spacecraft simulators, engineering models, telemetry, and real-time mission data. Mission controls tests, repair options before actually sending instructions to the astronauts. If we shut the system down, what happens? If we move power here, what happens? If we have this sequence instead, what fails? They simulated everything first. Only after testing the solution on Earth do they tell the astronauts what to do in their space. That decision-making approach helped bring Apollo 13 home safely. And this is the core idea behind any digital twin. When the real system is too risky, too expensive, or too far away to experiment on directly, you build a virtual version, test possibilities, and act with more confidence. So that was space. Then came jet engines. In the 1990s and 2000s, companies like GE and Siemens faced a similar problem. A jet engine was flying at 40,000 feet is not something you casually experiment on. One failure can really cost millions. One wrong assumption can risk lives. So they started using digital models to monitor engines, predict maintenance needs, and test failure scenarios before the real machine broke down. Then factories, turbines, power plants, and aircraft followed. And now healthcare is asking the same question. If we can simulate a spacecraft before we actually give instructions to astronaut, if we can simulate a jet engine before it fails mid-air, can we simulate a heart before surgery? Can we simulate a tumor before radiation? Can we simulate a patient's response before changing treatment? That is why digital twins matter in healthcare. Because in medicine, trial and error is not just expensive, it is personal. It is somebody's body, somebody's child, somebody's future. And that is where the story becomes very, very real. If you're still watching, you are exactly who TeqTalk is built for. Hit subscribe because what I'm going to show you next, the 3 real clinical use cases, is more exciting than anything I have described so far. Let's start with one of the most time-critical situations in healthcare, sepsis. A patient comes into the ICU with a severe infection. Within hours, the body can start shutting down. Blood pressure drops, oxygen level change, kidneys may start failing. The immune system overall reacts. And here is the scary part. In sepsis, doctors don't always have the luxury of time. Sepsis is one of the leading causes of death in hospitals. Some estimates show that it's about 1 in 3 patients who die in a hospital had sepsis during that hospitalization. Now imagine the pressure on the ICU team. They have to decide quickly, should we give more fluid? Should we change the antibiotic? Should we wait, or will waiting make the patient worse? For decades, this has involved clinical expertise, guidelines, and constant monitoring. And yes, some of the level of trial and error. But in 2020, Mayo Clinic researchers tested a different idea. So what if instead of only watching the patient and reacting, we could create a digital twin of the sepsis patient? Data-driven model built from patient's real ICU information, vital signs, blood tests, oxygen levels, medications, fluids, medical history, and treatment responses. The model asks a very practical question. If this patient receives this treatment now, what might happen to him in the next few hours? That's powerful because in sepsis, you cannot safely test 5 different treatment paths on the real patient. But if you can test possibilities inside the digital model, it's great. In the original 2020 Mayo-linked study, researchers tested the model using 29 sepsis patients and 145 observations during the first 24 hours of ICU admission. That was not perfect AI. This is important. The result was promising early evidence. The model showed fair to good agreement depending on the treatment response being measured. And Mayo did not stop there. Later work looked at larger sepsis data sets, close to 20,000 sepsis patients admitted to Mayo ICUs over the 8-year period, identifying different patients' trajectories such as fast recovery and slow recovery. Then, in 2024, Mayo researchers presented newer work around a digital twin model trained on close to 30,000 critical care sepsis patients. At 24 hours, the model was reported to predict 14-day mortality with 82% accuracy on Mayo patients and 78% accuracy on the external validation groups. Now let's pause here. This is a real promise of digital twins in critical care. The goal is not to replace the ICU doctor. The goal is to give the doctor another layer of foresight. But here is the honest part. This is still not routine bedside care in every ICU. It is still moving through validations, clinical workflow testing, physician trust, and regulatory questions. And that is exactly how we should understand digital twins in healthcare today. Not magic, not hype, but a serious move from reactive medicine towards simulation-supported decisions. In sepsis, where every hour can matter, that shift could be life-changing.